Okay, hello everybody. Everyone should be able to see my screen and should be able to hear me. If you have any issues, let us know. We can try to hop on and see what we can do. But for the sake of time as well, if you are having tech issues, I always like to say the best thing to do is literally to leave, exit, and join again. And usually that solves all my tech problems. So without further ado, let's go ahead and get started with our geriatrics webinar today. So I'm very excited everyone's here. Today's topic, of course, is geriatrics. That is my forte. My name's Annalise Caffrey. Recently Annalise Heaps. I got married just last month. So in the process of the name change stuff, which is a lot of work, by the way, guys. I don't know if any of you guys have had to change your names before. Um, but my background is I'm a family nurse practitioner. Uh, Got my doctorate a couple years ago in that. My background is specifically in geriatrics. I minored in gerontology. My doctoral project was on diabetes, specifically in a geriatric population. This is a group that I love. They're the group that's always early to every single one of their appointments. They either know more about their medication than everyone else in the clinic, or they don't know anything about their medication. And it's either one or the other. Never, you never know what it's going to be. No middle ground there. But let's talk about how we care for this population. They're wise, they're wonderful. I like to say they're wily, if I'm going to go with an alliteration there. But we definitely want to look at this from a board prep lens, from a clinical lens. How do you care for a geriatric population? Because in all honesty, they have different problems. They have different issues. We care for them differently. We treat them differently. We screen them differently. And because of that, I don't want you guys to miss anything that you need to know. So a quick disclaimer slide, no financial interest, no shady deals with a calcium supplement company here. It's just evidence-based info, a love for older adults, and a promise that I'm going to keep it really fast-paced, relevant, and hopefully a little bit fun. And plus, the great news is Archer Review is accredited by ANCC. So if you stay for the full hour, you're going to get one contact hour that you need to renew your license, whether that's nursing, APRN, etc. So stay with me, don't sneak off. And that contact hour, if you're on Zoom, will be emailed through you. For those of you joining on Instagram or YouTube, you can't get the contact hour that way, but for all the future webinars, we do a couple a week that are free. You can go on to archerreview.com, sign up there, and you'll get the contact hour that way. Here's our game plan. So what we're going to do today is we're going to break down how aging changes the body. So first we're going to learn that so you understand the basis of why geriatrics is different. We're going to learn about geriatric syndromes that are going to often show up on your boards or are very much going to show up in your clinical practice. And then we're going to nail down those things like meds, chronic diseases, falls. I want you to think of this kind of as your clinical cheat sheet. It's clinical cheat sheet meets exam survival guide. A little bit of both. We're going to talk about what you need to know for clinic, what you need to know if you're prepping for boards, and, bonus points. There's going to be a lot of practice questions, case studies sprinkled throughout so that you kind of get to practice what you're learning. So join us on Slido. This is what we're going to use throughout the webinar today. It's a really good way for people to engage because I've got a lot of you here in Zoom. I've got a lot of you on Instagram, on YouTube. This is going to be the easiest way for us to get everyone in one group. You can go ahead and scan that QR code with your phone, or if you are watching this webinar on your phone, you can just open up a Chrome tab, type in slido.com, and then you're going to put in this code. The hashtag's already included, so don't put another hashtag, just put Gero number 4 NP. So we'll hop over here. We're going to get started with just a few practice questions just to see if people are able to get into the webinar okay and understand that getting into the Slido. So we will give that just a few minutes for people to join in. And I want to know where you're at in your NP journey. Are you a student? You're a nursing student. You're not even in NP school yet. You're in NP school. You're graduating. You're just about to graduate. Some of you may have already just barely graduated, so congratulations there. And we will just take a peek at how that works for you. Student. I may have done this wrong because I think, okay, there we go. It's working for some people. I'm struggle busing because I am apparently not the smartest cookie in the shed. That's not even the phrase. It's sharpest tool in the shed, smartest cookie in the cookie tin. I just made that up. Okay, guys. Awesome. So we've got a couple different groups. We've got people taking their boards, retaking their boards, which never something to be embarrassed about. We're going to get you to that spot where you feel confident. You're going to pass with flying colors. If you pass grad school, I'm not worried about you. If you pass grad school, you're going to be an awesome provider, and boards is the only thing in the way right now. It's not a test of if you're going to be a good provider or not. It's just a test, and that's all it is. So we will make sure we go over all that stuff. You guys are going to feel totally confident. I've got a couple of you guys. See, look, it's not something to be embarrassed about. It's just test taking is a skill you learn. It's different than actually providing for someone in clinic. That's why I say that this is kind of where they meet each other, is that clinic versus that thing. And you guys are going to do great. Couple more questions real quick. Where are you guys joining from? I like to know where I'm seeing students from. That always makes me happy. I am, talking to you guys here from Utah today, and we're having that spring weather, that's always a little, I don't know, just weird because I don't know, it's yesterday, for example, was like 50 degrees, but then this weekend, 75 and sunny, just really rainy. So it just kind of bounces everywhere. North Carolina, Florida, Connecticut. Fun to have you guys here. I bet North Carolina and Florida are getting humid already. One of my best friends lives out in North Carolina. A travel nurse in Virginia, home is Florida. So you guys know humidity. New Mexico. Oh my goodness, we've got a good group here. Okay, one last question. I need to get a baseline from you guys so that we can see if I am effective at what I'm doing here, what I need to do better, and how confident you guys are kind of feeling so I know how in depth to go. How confident do you feel about caring for a geriatric client? Like, where are we at on that? Do you guys feel really good already? Do you not feel good? Like, where are we at there? Okay. I guess I like to see this. Geriatrics is my population. I like that we've got some people that are feeling really confident about caring for them, and some that are a little bit less. By the end of this webinar, guaranteed you're going to feel a little bit more confident. I feel like I can say that because I am the one teaching the webinar. Okay, this is good. This is exactly what I needed to know. Okay. Awesome job, guys. Let's see. I don't think whoop, spoiler alert, no one answered this yet. Okay. Yeah. Okay. Here we go. Back to what we're doing. Okay, this slide, this is your reminder that geriatrics is board gold. So you can't ignore this content. Up to 30% of the content you get on your boards is going to be about a geriatric population. 30%, guys. That's because as a primary care provider, especially if you're in school right now to be an FNP or even, a geriatric NP, your boards are going to be even more than that. So much of your population you care for is going to be geriatric because they are the ones that are having so many health issues. I mean, a 20-year-old comes into the doctor far more rarely than a 65-year-old. That's just statistics. So let's lean in. Let's really learn the things that they struggle with, how we care for them, what's different about them, so that you guys feel confident for this section. I call this my geriatric greatest hit list. I did a lot of research into this. So you guys feel free to screenshot this because we don't have time to really dive into each of one of these and where I got the research from. But this is very frequently what is seen. So I like to call this high yield prep, the greatest hits. It's everything you need to know, whether it's cognitive disorders, polypharmacy, falls, chronic illnesses, even how to spot a UTI that maybe presents as confusion. So we're going to hit on some ethical pearls. We'll hit on frailty, sleep and incontinence scenarios. This really, guys, is your roadmap. So if it's on this slide, plan for it to be on your boards. And I say that because I can't make any promises about what you're going to get on boards. I've only taken boards once. I don't know. And I would never tell you, yes, 100%, you're going to see this on your boards. But we know that 30% of your boards is going to be clinical geriatric questions. And so with that, wouldn't you say better to plan to see this information that's high yield, very testable, and know it rather than to be caught off guard? That's kind of my opinion. So that's why I call this very high yield. It is frequently seen on board certifications and very, very frequently seen in the clinic. So this is kind of what I say we must know. And I've got two more for you on this one if you guys were taking screenshots. So geriatric syndrome and ethics, these are all stuff between those two slides that I would say screenshot, take a picture of. This will be uploaded later on our Facebook page. So if you follow us on Facebook, you can get it there. But just don't forget, up to 30% really of your board exams is geriatric patients. So do not forget about this population. Don't forget this information. This is stuff you need to study. So first thing we need to talk about are geriatric changes, because you're treating an 80-year-old, let's say, their normal is going to be so different from your 40-year-old uncle's normal. So we really need to break it down by body system to kind of understand what makes them different so we know how to treat them differently. First thing here is cardiovascular and body comp changes. Older adults, their vessels get stiffer with age and their muscle mass decreases. So fat content goes up, muscle mass decreases, vessels get stiffer. And what that really translates to is that their blood pressure meds are going to work slower, and they're going to have that one glass of wine that just hits differently. Like they'll metabolize alcohol differently. They're more likely for breaks when they fall. Their skin's more likely for tears. On that cardiovascular side, you're more likely to see that isolated systolic hypertension, which I personally find really hard to treat. When their diastolic's normal, but systolic's what's elevated, that can be really hard to treat. And often it's going to require more than one med. So that's not something to worry about. Just remember, and we'll talk about it a lot more detail in a couple slides, but we always start low on blood pressure meds. We start low and go slow. With pulmonary and neurologic changes, it's very common for them to have some mild memory decline. Guys, remember, mild is the keyword there. It's okay for grandma to forget what she had for dinner last night, but to not remember your birthday, to not remember your name. Okay, not remembering your birthday is actually still pretty normal. But forgetting your name and she starts calling you the dog's name, that's where it starts to get more cognitive impairment, less mild memory decline. So for me, usually in the clinic, the first, and on boards too, the first indication for me that there's an issue usually, often it's family members that say it, or they report they're getting lost, they can't drive to the grocery store anymore because they forgot the route there and they've been driving to that same grocery store for 10 years. They forget close family members' names. That's all indicative of an underlying issue, not just normal changes, because what's normal is that everything slows down. It's like an older car is the analogy I use, which I wonder if is offensive to an older population. I don't mean it in a bad way. It's just an older car. I drove 1997 car I just barely got a brand new car. Drove it into the ground. Like it had, 300,000 miles on it. I was really putting the pedal to the metal there, but it worked. It just worked slower. The battery died more frequently. I had more issues. It needed more tune-ups, but it still worked. It still ran. It was a car. Pulmonary changes, lungs get less elastic. So imagine a rubber band you've left out in the sun. It doesn't pull and bounce back normally like it does. That's what happens with our lungs as we age, especially those that have had a lot of environmental risk factors or they smoked. That elasticity decreases. So they're going to have a longer expiratory flow to get that air out of their lungs. And they're also just going to have that blunted cough perception, blunted dyspnea perception. So that is what's important to know, because it's going to affect disease presentation. They don't cough as much as a 25-year-old does with pneumonia. So you want to look for those other signs that may be indicative of disease, not just the stereotypical signs you see in a younger adult. Metabolic and renal changes, stomach slows down, you have less stomach acid, so that's going to affect, of course, metabolism of medications. So drug clearance, drug absorption, those are all going to be affected if you think about it logically. Like if it takes longer for them to digest food because they have less stomach acid and slower motility, you got to think about the fact that they're at a higher risk for toxicity of drugs, because it's going to absorb really slow, it's going to stay in there for a long time, can be toxic. So things to think about there. They also have higher fasting glucose levels, just because the pancreas, just like everything else in the body, starts to age. So with that, the body doesn't bounce back as fast from like highs or lows from glucose. So we really try to keep them at a steady level, and we kind of loosen up the reins there for glycemic control, because they're at higher risk since they have that blunted low glucose. Normally when someone's glucose gets low, like I struggle with my glucose. Like I'll get low in the mornings if I like, because I don't like to eat breakfast, and I'm a chronic passer outer. My husband says it's embarrassing. I just pass out all the time. He's always worried about it. So with that, we kind of let up the reins. We let them have, more of a higher A1C or something, because we don't want them to be passing out and falling. Renal changes, know that creatinine can lie. So low creatine, creatinine. I can't remember which one I'm saying incorrectly. Either way, when that is low, it's because they have low muscle mass. Because remember, that's not just found in the kidneys, it's found in skeletal muscle as well. So it can kind of mask kidney disease because we normally see that go up with kidney disease. So normally I would tell you, like in a 25-year-old, a really high level of that could say, oh, maybe they have something wrong with their kidneys. But in an older adult, because they don't have as much muscle mass contributing to that number, it could look normal when really it's super high from the kidneys and really low from the muscles. So that's why we always look at estimated glomerular filtration rate, or that GFR. Know that it does drop 8 milliliters a minute per decade after 40. That's just normal. As we age, it drops 8 milliliters per minute. When we're trying to say, above 100 is normal, above 60 is normal. It drops almost 10 milliliters every decade. So that's like 1 milliliter a year, really, after we're 40. So we expect our kidney function to decrease. The cool thing is we really only need a very little amount of our kidneys to function for to be able to live a normal life. So those are all things to think about. We know bladder changes, incontinence becomes more common, even though it's not normal. We'll talk about that later. Pelvic floor muscles can also kind of contribute to that, especially in men when the prostate starts to get big. The joke in my family is that I can always tell the age of a man using the bathroom by their stream, which is weird because why am I listening to men pee that frequently? But it's just the bigger the prostate, the harder it is to start the stream. To stop the stream, you kind of get that spurting where it's like they start peeing, stop peeing, start peeing, stop peeing, because that urine has to pass through the prostate. And when that gets really big and bulbous, which starts to become more normal as men age, it affects their urine stream. So that's definitely something to think about, and we'll talk about it later when we get to the kidney section. And then last couple things, their sensory changes and their sleep-wake cycle. So we know that they're going to have hearing changes, eyesight changes. They're going to have, guys, I have given this webinar a bajillion times, and every single time I say I'm going to fix that slide, and I forgot again. Presbycusis, whatever, that is hearing loss. And the presbyopia is the difficulty focusing on near objects. Just so you know, I'm sorry, that's on me. I just remember presby means old. So that's kind of how I remember what these terms mean on a test. And then the opia, I think optic. So that's how I know that's the one for the eyeballs. And then the cusis, I don't really have any way to help you guys remember this other than like percussion. It kind of looks like cushion, if you talk about people playing the drums. For me, it's just easier to know that if presbyopia is the eyeball one, the other presby one is the ears. So that's my little tip there for you guys. Nerve conduction slows down, so they have a slower response to stimuli. Let's say they put their hand on a hot stove. Me at 27, I'm whipping my hand right off. My reflexes are hot. They are going to leave their hand on for a little bit longer just because it's going to take longer for those nerve endings in the hand to travel up the spinal cord, up to the brain and say, hey, that's really hot. And to come back down and say, ooh, lift your hand. So same thing with like in their feet. It's why it's really important that we teach, especially diabetics who have extra bad nerve conduction in their feet, to check their shoes, never put their feet in hot water, things like that, because they're not going to feel it as much as they would when they were young. Sleep-wake cycles, insomnia is going to be a really big issue in the aging population. It's due to a lot of different things. They're going to have more nighttime awakenings because they have to use the bathroom, because their medications they're on, life stressors. They spend less time in REM. That's just a thing as we age. And so with that, we want to make sure that we are assessing for sleep-wake cycle changes because it can really mimic dementia and can cause dementia long term. So it's important that our older adults are getting enough sleep. Okay, that kind of gets us through all of those changes in the body. So I hope that was a good look at how the body changes so that as we spend the rest of the time talking about these actual changes, you understand what's normal so that you can recognize what is abnormal. So polypharmacy, aka this is geriatric bingo for me. How many meds can one patient be on? The best way to look at polypharmacy from a clinic standpoint is what we call the brown bag method, which is having them bring all of their medications, all their supplements, all their herbal remedies. And that's really important to stress that. A lot of time people think medications are only what is prescribed. That's not true. Ibuprofen over the counter. That's still a medication. Acetaminophen, still a medication. Their their supplements they're taking, their glucosamine they're taking for their joint health, their multivitamin, their omegas, those are all medications that I need to be reconciling to see if they interact, if it raises their risk, if it's contributing to a symptom. So you have them bring everything in because I have an aunt, and I tell the story every time I give this webinar, bless her sweet soul. She we just went out to lunch. She's a great aunt, by the way. So she's 82 years old. We went out to lunch because she also lives here in Utah with me. And I was asking her how things are going, how her health is. And she's like, oh man, my doctor's got me on 10 meds. And I'm like, oh, 10 meds? That's a lot of meds. That's polypharmacy, really. Because as you can see here, polypharmacy is 5 or more meds. Anyone who's on 5 or more meds, regardless of age, is considered to have polypharmacy. And side note, that does include over the counter and herbal supplements. So she tells me that. I'm like curious now. I want to know what she's on. I'm like, oh my goodness, what are you on? She goes, I don't know. Like there's like this one pill, it's like purple, and then there's like this other one I'm taking, it's blue and circular. I'm like, oh my goodness, you need to know what you are taking. My grandma pipes up at the table at the same time. She's like, yeah, I don't know what I'm taking either, Annie. That's normal. I'm like, grandma, that is not normal. You should know what meds you're on, why you're on them. And that's a part of our job as providers in patient education. So I'll get off my soapbox there. But with polypharmacy, it just increases the risks. If you think about it, we know that metabolism slows with age. That's normal. We know that kidney function slows with age. That's normal. That is then going to cause slower metabolism of the drugs, and that's going to cause an increased risk for adverse drug reactions, those ADRs. Our goal as clinicians is to always have the best outcomes for medications and the least side effects for medications. That would be like in a perfect world, every drug someone took would be awesome for them and there'd be no side effects. Obviously, we don't live in a perfect world, but that is still our goal. We want there to be the least amount as possible. So these are all things to talk about. Any med we put an older adult on, we start low and go slow, especially drugs like blood pressure meds, thyroid meds. Those all require us to go really slow because of those increased risk for drug effects, drug interactions, prescribing cascades. So all things to think about. This is the Beers criteria list. I included here a QR code if you are on your laptop and you can scan this, or you can screenshot this picture and later take a picture with your phone. This is for the Beers app. It's available on Apple or on Android, whatever phone you have. It is, I will be honest, it's a little bit of a fee. It's pretty minimal if I remember correctly. I'm a cheapskate. I'm as cheap as they come. And for me, it was worth the money. So I think that says something that I was like, yes, this is worth the money. I use it in clinic all the time because the Beers criteria, you can find a PDF online that you can download for free. I didn't include that because I don't know what the legalities are there, but just up front between you and me, there's PDFs of it. You can just download for free, keep them on your phone. It is really, really long, and there's a lot of drugs. Like maybe if you're a pharmacology student, that would like be really interesting to you. That's hard for me to remember that many drugs and how they interact, what's safe, what's not. But really the whole purpose of the Beers criteria is to tell you what drugs we really should be avoiding in an older adult population because of the side effects and how drugs metabolize and distribute differently in an older adult body. And so this app is awesome because it kind of walks you through, like you can just input a drug and it will tell you what the Beers criteria says about that drug. So I would really recommend that app if you're looking for something. I have a whole folder on my phone. That kind of is, I call it my medical folder, my work folder, and it's, my up-to-date subscription, my Hippocrates subscription, my Beers criteria app, my United States Preventative Task Force app, all the things that I really like. So feel free to email me at any point if you're like, oh, Annie, I want to know what apps you have that you use. I'm happy to go through those. But I included here a table for you of just really the most common ones, the real big heavy hitters. Take a screenshot of this. We won't talk through all of them because we don't have time today, but things like NSAIDs. NSAIDs on the Beers criteria list are really considered a no-no in older adults because of that risk of GI bleeding, the risk of kidney injury. So they really say if you have to use an NSAID for things like osteoarthritis, etc., you have to co-prescribe it with a PPI to protect their stomach. So like that's really good information to know. And like muscle relaxants, they have that anticholinergic sedation effect that we really try to avoid in older adults because it can be considered unsafe. So this kind of is a good list. Screenshot it, look at it later when this gets posted on Facebook, just of things to avoid because they're unsafe. Now we're going to talk about deprescribing because you know about polypharmacy now, you know how many drugs, all these drugs that are considered unsafe. We want to deprescribe. It should be one of our goals when treating geriatrics, especially the fact that, such a large portion of the older adult population is on over 5 medications. Like it's the majority of the population is considered to have polypharmacy. So with that, our goal should be deprescribing. That means you have to do the brown bag method, look at everything they're on in the dosing, and then start to say, why are they on these drugs? Do they need to be on this medication? Are the side effects and risks of this medication worth the benefit? Because one of the things we get are these prescribing cascades that I talked about a few slides ago. And what that means, a prescribing cascade, if you think about a waterfall, which cascades, into one, into another, into another. Same thing with prescriptions. We get into the cycle where we prescribe something to treat a symptom of another medication. So the example I always like to give is the client comes in, they have high blood pressure, we put them on an ACE inhibitor. They come back a couple months later, now they're complaining about having a cough. Okay, well, we put them on cough syrup. Then they come back a week later, that cough syrup's made them feel really sleepy, those anticholinergic side effects. Now we put them on something else for that. Where we have now prescribed 3 medications to treat the symptom of a dry cough that we know is associated with an ACE inhibitor. We would have been better just switching that ACE inhibitor to maybe an ARB, like valsartan, that doesn't have that side effect of the dry cough nearly as much as something like lisinopril does. So we want to avoid prescribing cascades. And this is something that should be done at every single visit. Every visit they come in, we should reconcile their meds. We should look at dosing, and we should avoid that pill for every ill mentality, do non-pharmacologic treatments first, and then deprescribe anything that is not like immediately necessary for their condition. Got a practice question for you guys here. We'll hop back to the Slido in just a second. Okay, here we go. Oh my goodness, someone already answered this. I love it. You have an 80-year-old female. She presents to the clinic with complaints of chronic dizziness. Her medication reconciliation reveals long-term use of alprazolam for situational anxiety. What should your next course of action be? Let me know what you guys are thinking. Taper, switch to another prescription, review all medication they're on, see about starting to wean the patient off. These are great answers, guys. These are really awesome. Okay, great job. We'll hop back to the slide just because we've got so much to go through. But I really love that you guys said taper and wean. Those are great answers because really anytime someone's on a benzo, remember, we have to wean them off it. So normally the protocol right now that's evidence-based practice is about 10 to 25% over 1 to 2 weeks. So you do that, taper them off of it slowly to prevent withdrawal. That's a drug that she doesn't need to be on that has more side effects than it does benefits for an older adult population. Whoops. Okay. And then last thing I'm going to say here on polypharmacy is that anytime a new symptom arises, this is both for clinics and for board prep. If a client has a new symptom, especially if they're an older adult, you should always, always, always first suspect it to be a medication side effect. And then you can say, okay, actually, maybe this acute confusion is a different issue. But first, you always say, could this be caused by a medication? That's the first thing you think of. Okay, quick breather here, guys. We're 30 minutes in at this point. I want to go over some Archer Review NP. I saw some questions down below in the Zoom chat, people asking about our offerings, asking about signing up for a 3-day live review. We do have a lot of different offerings. The best way to just see everything and to kind of get some demos, I would say, would be to go to archerreview.com and click on our FNP page. We have a lot of different offerings. We have on-demand videos that you can watch on the go with, over 16 hours worth of content. They're bite-sized videos that kind of similar to webinar outlines in that regard. We break down that must-know content for you. The QBank, we've got over 1,600 questions. There's a readiness predictor that will tell you how ready, especially for those retest takers. It will tell you how ready you are for your boards, how likely you are to succeed. And we recommend you get a couple of those in a row that say you're highly likely before you take your boards. 3-day live reviews, we offer those kind of sporadically throughout the year. We don't have one scheduled right now because we're in full full steam ahead working on this really big project that I'm excited to launch for you guys here shortly. And so the whole team right now is just pedal to the metal, getting this content that I would have killed for to have when I was in grad school. So that's super exciting. We also did just launch clinical skill videos earlier last year. I am in a lot of them, so you'll see me. Oh, it's Dr. Caffrey. I'm showing you how to do blah 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 today. They're professionally filmed and they walk you through with really good camera angles how you need to do clinical skills. Like, for example, suturing. We've got a really great video for you on the simple uninterrupted suture, because suturing was a hard skill for me to learn, and the videos that were online were like from the 80s or the 70s. So we wanted to get some really good high quality content out there for you guys, because sometimes it's easier to see it than to explain it. So once again, here's my email. Pop that, screenshot that. I'm happy to answer any questions for you guys. And then that QR code there takes you to all of our socials. We've got Facebook groups where we post questions every single day. I make a lot of the content for you guys on there, with as far as like Instagram posts for what I think are things like this week we're talking about chest pain and the 5 must ask questions for chest pain. So all stuff that you don't want to miss. We go live with our webinars on Instagram, TikTok, all that stuff is things you want to subscribe for. So don't forget to use that QR code. Okay, switching gears here. We're going to talk about cognitive and mental health in a geriatric population. And if you don't know how to differentiate dementia, delirium, depression, by the end of this next half hour, you are going to, because this is board prep gold. This is high yield. You are, once again, I can't promise that you're going to get a lot of questions on it, but it is likely. This is a highly tested, and then a highly seen issue in the clinic. So this is stuff we want to know. Okay, pop quiz real quick, guys. What is the most common type of dementia? I'm just going to give us like 30 seconds here to talk about this. So I will just give you that just for 1 second. Alzheimer's disease. Awesome. You guys got it. Hit the nail right on the head. That is amazing. That is exactly what it is. And with dementia, because Alzheimer is the most common of them, they have the 5 A's of Alzheimer's. This is just kind of something that someone put together. I don't even know who it was. These are the 5 fancy medical terms that I would really recommend you remember. So screenshot this, because they are very similar to each other in looks. I made flashcards when I was in school for this, because they like to test on it in school. They like to test on it on boards. They like to use it in charting when you're charting, especially since a lot of the patients I see in a clinic setting are geriatrics. These are terms you're going to want to use for your charting. So I made flashcards just so I didn't mess them up. You want to remember these 5 A's. And then the other little tip I would give you guys on this slide is that dementia is not just that regular mild decline. It's when you have 2 cognitive domains, whether that's memory, executive function, language, etc., any of those are affected to the point that it interferes with their daily life function. So when they can no longer dress themselves, feed themselves, they can't communicate with their friends and family, they can't get themselves to the grocery store. That's all when it becomes dementia. That, those beginning stages when it's really early, it's just mild decline, they can't remember what they ate last week for dinner. That's not as much what we're worried about. Of course, we always want to track it so that you know if they're declining and getting worse. But for the most part, what you're going to see is in the early stages, they're going to have preserved social functioning. It's not going to interfere with their daily function. As the disease starts to get more advanced, that's when they're going to wander, get lost, and it's really going to affect their day-to-day life. There are a couple other types of dementia. These you won't see as much in a clinic setting. And if you do see them, it's going to be something you more don't manage yourself. You're going to, for the most part, depending on if you're really rural, you might manage this yourself. But if you're in a big city, you're going to refer this out to neuro. But it is important that you can recognize the signs and symptoms. Vascular dementia, like the name implies, is a vascular issue. So they're going to have a history of strokes, MIs, TIAs. They're going to have neurologic signs that go with that, more like you'd see with a stroke. Whereas Lewy body dementia, that's more associated with Parkinson's disease. So you're going to see those Parkinsonian symptoms, that shuffle, the shaking, and early vivid hallucinations. That's like keyword for Lewy body dementia. If you ever get a question on your boards that talks about early vivid hallucinations and cognitive decline, you should automatically be setting off warning bells for Lewy body dementia. And then lastly, frontotemporal, the big indication of that one there is going to be when they say it has just been like they're really young. So usually they'll be like less than 65 and just a major 180 personality change. Like grandma was so sweet, attends church every Sunday, doesn't swear. All of a sudden she's cursing at the TV, cursing at grandpa, just really grouchy. That's going to set off warning flags in my brain that we may be dealing with frontotemporal dementia. Once again, just here as a quick little side note, mild cognitive impairment is when you still have that preserved function. So, you know how I was saying over here, interferes with their daily function of life, that for mild cognitive function, it's not interfering with their daily life, but about 10 to 15% of those cases every year do progress to dementia. So that's why even just with mild cognitive impairment, we always want to monitor it. We want to be doing assessments and we want to be, preventing further decline. So that means, promoting exercise, promoting cognitive engagement, puzzles, Sudoku, etc. Treatment of these diseases, there's really not any cure, but we are starting to get a lot more ways to slow down the progression. The sad thing is a lot of these only work for so long. So I'll have patients that come in and their family's super excited because, they got their old grandpa back for a couple months, and then the longer they're on that medication, the more they use it, the body kind of, I don't know if it's just the body adjusts to it, but it stops having its same effect. So, cholinesterase inhibitors like donepezil, that's going to be for Alzheimer's. That's going to be more of like a first line medication for them, because that's going to slow symptom progression. As that drug stops working, the dementia starts to progress worse. That's when we add in memantine, which is more for that moderate to advanced stages. So more when they're getting lost, they're not eating, they can't get themselves dressed. That's when we add that medication in. So, the other thing as far as treatment goes, this is something to avoid, not a treatment. Anticholinergics. You never prescribe an anticholinergic for someone with dementia or someone with mild cognitive impairment, because it has been shown in studies to worsen dementia. That anticholinergic effect can make it a lot worse, actually. So we definitely don't want to be prescribing that. Non-pharmacologic management is going to be the best thing as an APRN that we can do. Caregiver support is going to be really important. That is a really big burden on caregivers, especially when you're talking, they are losing their spouse in real time. Their spouse can't remember their name anymore. Their spouse's personality changes. They're losing weight, etc. And oftentimes they'll become the sole caregiver. They've been married for 60 years. It's their best friend. And now all of a sudden they're the one changing their diapers, getting them dressed, feeding them. That's really, really hard. And so we want to make sure that they have the support, both emotional and physical. So whether that's physical therapy, occupational therapy, in-home care, hospice, etc. We want to be advocates for that, know the resources in your area and what we can sign them up for. We also want to make sure that we're educating about end of life documents, because we know this is something that's going to get worse. So then as providers, we want, while they're still functioning, they're still with it, that they're making decisions about how they want their end of life care to take place. So we want to talk about that stuff early on and then address all those safety things like driving, eating, cooking safety, fall risks. All of that needs to be done at earlier appointments rather than later. Parkinson's disease, this is more of a progressive degeneration of those dopamine neurons. So risk factors, of course, are going to then be aging. The older you get, the higher the risk factor is for, just because it's a progressive degeneration. So everyone is losing a few dopamine neurons. That's normal. They're losing a lot more. And so, higher risk. Also, you can have a genetic predisposition. So people that have a family history of Parkinson's disease, I'm always more worried about. And then also those that have been exposed to some chemicals. So I always ask about what they did for work, where they grew up, things like that we do know are linked to Parkinson's disease. You'll see the symptoms. They'll have that tremor at rest. They move really slow. So it's like they're tremoring, but then also it's like to go get their phone, like it just happens so slowly. They're very rigid, so they can kind of develop claw hands, claw arms. They hold their muscles really tight, almost kind of to try to stop shaking. So everything's rigid as they're tremoring. They're going to shuffle that gait so they won't pick their feet up. It's literally called like a Parkinson's gait, that ataxia, where they just shuffle hunched over to get where they're going. That is the biggest indication to me. The other biggest indication that I see in clinic is family members coming in saying like, He's just totally apathetic. Like no facial expressions, nothing changes, like doesn't smile, doesn't frown, doesn't look sad, doesn't look happy. That indicative of Parkinson's disease. So those are all things to think about. Also, the voice changes. When people start to say that they sound different, their voice doesn't sound the same, think Parkinson's disease. You'll often refer this out to neuro, but starting with a good history, a good physical exam, and then a brain MRI. Those are great spots to start. And we do treat this with levodopa and then dopamine agonists like ropinirole. Anticholinergics are a treatment for this one, which is weird because remember, for dementia, 100% do not prescribe an anticholinergic. They are used in Parkinson's disease. Sad thing about Parkinson's disease is that, like the other ones we talked about, these medications work for a little bit, and they'll slow the disease progression. My husband's grandma has Parkinson's disease, and she's on all these medications, every one of them, and it has really helped slow her progression. If you saw her just like eating lunch with me, you wouldn't think, oh, she's got Parkinson's disease. But we all know that it's something that is going to progress and get worse with time. So that's something to educate patients on, is that it slows progression, but it is not a long-term treatment or cure for the disease. Okay, quick quiz again. What's the most common cause of delirium? Who knows the answer to this one? Most common cause of delirium in the elderly. I'll give you guys just like 30 seconds to quick pop this one in, and then we'll continue on. I'm just curious if people are comfortable with delirium. That's one that can easily get mixed up with depression and dementia. So let's see who feels comfortable. UTI. That is a great answer. Medication or UTI, infection, depression. Loving all these answers, guys. Technically, it's considered just infection. I mean, of course, a UTI is an infection, but yes, an infection is the most common cause of delirium. Delirium, different from dementia. Remember, dementia, you're thinking those terms: chronic, progressive. Delirium is acute and fluctuating. So it's not like they're constantly getting worse. It's all of a sudden, bam, someone brings in grandma to the ER and they're like, she was fine a couple hours ago. All of a sudden, she's speaking gibberish. She doesn't remember my name. That is delirium. That's not dementia. That's not a chronic progressive issue. This is something that is treatable. It's going to alter their consciousness level. It comes on fast, over hours to days, and it needs to be treated. There is always an underlying cause to delirium. Where with dementia, oftentimes there's not an underlying cause that we know of yet. Triggers, medications, super high. Infections, super high, especially UTIs, like was said. Pneumonia is another big one. Metabolic disturbances, remember we said their glucose in older adults bounces a lot more than it does in younger adults. And then electrolyte issues like low sodium, high sodium, things like that. Withdrawal from medications, that kind of goes up to medications again, especially benzodiazepines can cause delirium. So know that on your boards or in clinic, if you get an elderly patient with an acute mental status change, it is always delirium until we can prove it otherwise. So unless I can prove that it's not an underlying cause, this is dementia, this is a, psychotic break, something like that, it's considered delirium, and it needs to be treated. We need to find that cause. Other cognitive changes to that are acute with delirium, the way we manage it is, like I said, there's always an underlying cause. You want to find out what that cause is and then treat it. So an antibiotic if it's an infection, correct the electrolytes, etc. You're going to want to give really great supportive care. So reorient them, make sure their room's well lit, etc. The thing we're going to want to do is avoid additional medications, because we know that medications can cause delirium. We really want to try to keep them off medications that can worsen delirium. Like benzodiazepines, for example. If you have to have a medication because they're really agitated and it's a safety threat to themselves or other people around them, that's going to be more when you use the low dose haloperidol or other antipsychotics, because that is like, we have no other option. In a lot of cases, that can worsen the delirium. So we try to avoid it and use that as a last resort. Cognitive screening test. This is another table I made for you guys. Screenshot this. This just is a quick comparison of the different screening tests we have, like MoCA, MMSE, Mini-Cog, SLUMS, clock drawing. The one I use most in clinic is probably going to be the MoCA test or the MMSE, the Mini Mental Status Exam. Those are really great for general screening, and they can track mild cognitive impairment, especially the MoCA exam. So there are 30-point tests, both of them. bunch of different questions. They look at, executive function, memory, recall. It looks at different forms of functioning and cognitive functioning, and then it tracks how they're doing. So this is a really good way. I try to start this early on my patients, even before people are complaining. If they just say like, I forget where I'm putting my keys. I then on that visit do a MOCA, a MMSE, a slums test, etc. So that next time they come in, I can do another one and we can see if that score is getting lower. A lower score means higher risk for dementia, higher likelihood that they have an underlying cognitive issue outside of just that mild cognitive impairment. Okay, depression. This is the last thing we're going to touch on in that trifecta of dementia, delirium, and depression. Depression in older adults is really, really underdiagnosed. A lot of people just think, yeah, they're old. Old people are sad. Old people spend a lot of time alone. Old people have nothing to live for. Like, there's a lot of stereotypes. And ageism out there that is not accurate about older adults. And for that reason, a lot of older adults, especially that generation right now, they don't want to think that maybe they have depression. They're too strong to have depression. And so they don't ask for help. And then oftentimes we miss as clinicians because if you don't recognize that their symptoms are going to present atypically, you'll miss it. So while like a teenager is going to come in and say like, yeah, Annie, I want to kill myself. My girlfriend broke up with me. Like my life sucks. You're going to see less of that in an older adult population. You're going to see them be more apathetic. So like, someone who loves gardening just stops gardening. They stop eating. They're not sleeping. Don't just assume that that's dementia, that that's a normal aging change. That could likely be depression. Um, and it's going to look more cognitive. So it's going to look like dementia in that maybe they're going to have like be forgetting things. They'll be forgetful. They'll be apathetic. They'll be tired all the time. Things that maybe you don't think, yeah, that 100% is depression can be depression in an older adult. The other thing to know and why it's so important, not only just because we care about the quality of life in our older adults and we don't want them all just being super depressed, but also their suicide risk is extra, extra high, especially in older men, older white men who have lost a spouse in the last year. That is the highest risk of any population for suicide. So we always ask about suicidal thoughts when we're screening for depression. We want to make sure that we don't miss that. I think it's extra high risk, especially because they feel like they're at the end of their life anyway. So it feels less drastic killing themselves at, age 80 than it did at age 20. And so we want to make sure that we don't miss those suicidal ideations, that suicidal behavior that we're always screening. We screen with the PHQ-2 first, that just asks 2 questions really quick. And then if either of those they answer yes to, that's when you move on to the PHQ-9, which is a full depression screening. There's also the Geriatric Depression Scale, the GDS. I really like that one. Its questions are a little bit more specific to a geriatric population because, like I said earlier, they present atypically. So that'd be my preference, but a lot of clinics screen everyone regardless of age with a PHQ-2, and I appreciate that they're putting effort into not missing this population. Anxiety kind of goes hand in hand with that. It presents as excessive worry, whether that's about their health or their finances. We want to once again avoid things like benzodiazepine. I have a lot of 85-year-old patients coming in with falls and dizziness and vertigo. That is because they've been on a benzodiazepine 3 times a day for their anxiety. Buspirone, I think, is a really great option that's non-sedating for generalized anxiety disorder. So for GADs, I like buspirone, especially in an older adult population. Other than that, SSRIs are our first line treatment for both anxiety and depression. In an older adult population, sertraline and escitalopram. Those are going to be your 2 ones you should think of for older adults. That's not to say that you can't use the other ones, but research shows sertraline and escitalopram are your best options for an older adult population because of a lot of SSRIs prolong the QT interval, have a lot of side effects. So these 2 are our best. You want to make sure you start with the super low dose and that you're educating that it does take like 8 weeks for full effects. So they may not feel different for the first little bit. And we need to be following up. We need to be watching for suicidal ideation. Never prescribe a TCA. Those tricyclic antidepressants should never be prescribed to an older adult because they're high suicide risk, high fall risk because they're anticholinergic. So if you get a board prep question where a TCA is an option, it's never going to be the answer. You never prescribe a TCA to an older adult. And make sure that you're also talking about therapy options, social engagement. A lot of times the depression is caused by the fact that it's very situational. Their life has changed. They've lost their spouse. They're living in an, they're living in a facility now and have had to move out of their home. They don't have a job that they've had for the last 45 years. So they can feel a little lost and without purpose. And so social engagement and cognitive behavioral therapy are going to be really great ways to engage older adults in addition to medication. Now let's talk about falls, mobility, and bone health. Um, Falls are a lot like toddlers because they happen all the time in a geriatric population. They come out of nowhere and they're a major cause of chaos. In fact, I'll let you guys know falls are like the #1 cause of injury and hospitalization in older adults. So you always want to make sure you're asking, have you fallen in the last year? And if they say yes to that, you're going to do a tug test. The timed up and go test. What you do is you have them stand up, walk 10 feet, turn around, come back to their chair and sit back down, and you time them during that. If it takes them longer than 12 seconds to perform that task, they're considered high risk for falls. You also always want to perform a meta reconciliation, check their blood pressure, vision exam, all the normal stuff you check, but make sure that if they say they've had any falls in last year, you are definitely doing a timed up and go test because we can get a lot approved by insurance if we have it documented that they're high risk for falls. So we can get them occupational therapy, physical therapy, we can get them assistive devices like canes or crutches, walkers, etc. So we always want to make sure that we are accurately documenting falls in an older population. Um, the US Preventative Task Force does in fact recommend strength and balance training. So a lot of times like a gym membership will even be covered by insurance there for individuals over 65 because they should be getting that at least 2 days a week is their recommendation. So things like Tai Chi, strength and toning classes. And then there's just the safety things. Talk to them about mobility tools like bars in the shower, non-slip mats, getting rid of rugs, grab bars, etc. All of that is going to help prevent falls, which of course is one of our #1 priorities as a provider because it is one of the #1 causes of hospitalization, and we're trying to prevent hospitalization. Orthostatic hypotension, we talked about this being, of course, one of the big things to check. It's one of the big causes of falls in older adults. What orthostatic hypotension is specifically is it's that autonomic change where standing up becomes like an extreme sport for older adults. They lose that reflex blood pressure control and then boom, dizziness, they fall, maybe even they faint. Best fix for that's going to be hydration and then educating them to rise very slowly. And then maybe we need to reduce their blood pressure meds. A lot of people have been on their blood pressure meds since they were in their 40s to manage high blood pressure. And at this age, they don't need to be on that many medications at that high of a dose. And we can often cut back, deprescribe a lot of those blood pressure meds, still keep their blood pressure in a good range, but reduce that risk of falls. Osteoporosis is really sneaky. That's that bone health one we're looking at. Bones can look normal on the outside. You don't look at them and think, yeah, they have bad bones. They've got osteoporosis. But inside, they're crumbling. They become really porous and fragile, like a stale croissant. Like if you've ever left a croissant out and you crunch it, all those air pockets, they just fold in on themselves and crunch. Biggest thing for osteoporosis is going to be getting a DEXA scan. We start those at 65 years old for women. That's from the US Preventative Task Force. And younger if they have risk factors. So every woman 65, every 1 to 2 years, start younger if there's risk factors. For men, we start at 70 with risk factors. So other than that, men just have better bone density than women. And especially after menopause, when that estrogen level drops, our risk for osteoporosis goes up. So, of course, you're going to want to educate to get weight bearing exercise. Swimming's not good for that, but walking is, running if they're able to run, pickleball, tennis, anything that they're bearing weight on their bones prevents good bone health. You're also going to want to get that DEXA scan, like I was talking about. You should know these T scores, so take a screenshot of this page. Osteoporosis is considered a T score of -2.5 or less. So like -3.5, -3, -5, those are all going to be considered osteoporosis. -1 to negative up to -2.5, so -2.4 is osteopenia. And then that normal is to -1. So +1 to -1 is normal bone density. You're going to want to memorize this one. It's pretty testable, and you'll see these numbers a lot in practice because you're going to order a lot of DEXA scans, right? Because they're recommended, right? Okay. Treatment, like I was saying, of course, first line is going to be supplementation with vitamin D, calcium, 1,200 milligrams of calcium a day, 800 to 1,000 of vitamin D. Those are all going to be good. If the risk score starts to get really high, like they have a high fracture risk, so greater than 3% or a hip fracture, you're going to want to go to your second line treatment, which is bisphosphates. So things like Fosamax, if you guys know that one, or alendronate, those are bisphosphates, and those are taken once weekly, which is really awesome because they don't have to remember to take it every day. But they do need to take it in the morning on an empty stomach and with a full glass of water. That is really, really important. And so is sitting upright for 30 minutes after. Super important both for clinical education and for board prep. That's highly testable because bisphosphates are really irritating to the esophagus, so they can cause esophagitis. So we want them to stay upright, take with a full glass of water to kind of flush it down and protect the esophagus. Also, this is one of those meds that you do hold if their GFR is less than 30 to 35 because it's hard on the kidneys. So also remember that. Okay, we've got a practice question now. Mrs. Jones has Mrs. Jones 73, frac score 10%, hip fracture up 4% over the next 10 years. T-score is negative 2.8. So if you guys remember T-scores, where does that fall? Osteopenia, normal bone health, osteoporosis. They decided to prescribe Fosamax weekly. What statement indicates that they need more teaching? Okay, give you guys just a second to answer. What is the right answer? Meaning the wrong answer. Seeing some answers for that. C, plan to take my medication at bedtime. We'll hop back over there. Great answer, guys. C indicates further teaching. You should not take it at bedtime. That's taken in the morning on an empty stomach. Otherwise, it's going to increase that risk of esophagitis. Very dangerous to our patients. Okay, now let's zoom out and look at the body's largest organ, which is skin. I have a couple things here. Lentinges, those are solar spots. You'll also called liver spots. They're totally benign unless your patient wants you to laser them off or freeze them off, but they're not going to ever become cancer. They're like those brown spots on the skin. Best thing for them is going to be wearing sunscreen, avoiding the sun to prevent them becoming worse. Stasis dermatitis, I call these cranky calves. Think itchy, swollen, red. It's often misdiagnosed as cellulitis, which is a bacterial infection. These are just inflamed, so they get ulcerations. It's because of decreased blood flow down to the legs. So you're going to want to treat the symptoms, treat the swelling with compression stockings, and then things like steroids or moisturizers and NSAIDs can help with the pain, the itching, the scaliness. Actinic keratoses, you should definitely know that these are technically not considered benign because they are a precursor to squamous cell carcinoma. They're those little rough scaly spots. You'll see them most often where you get a lot of sun exposure. So in men, especially like golf dads, sun worshipers, they'll get them on their ears, on their nose, on their forehead. Those need to be frozen off or chemically peeled off with like 5-fluorouracil. I can't even say that. 5-FU is what I call it. So those chemical peels or cryotherapy because they can become squamous cell carcinoma. And SPF is really your best friend and your patient's best friend. That's what I always tell them. I tell my patients it's cheaper than lasers and it's less painful than skin biopsies. So I always recommend to wear sunscreen every single day of the year is the first thing I put on my face. So then you have senile purpura. These are these dark purple bruises. They look worse than they are because they're totally benign. They're really dramatic, big purple bruises. That's just because they have less collagen and less cellulose in their skin. So their skin's really thin. They bruise easily. So they're just bruises. It's not abuse. Usually it is definitely something to watch for, especially if you see a lot of them that are not healing. It's just aging vasculature and it heals with time. Now we're going to look at a couple of geriatric syndromes. Incontinence is when urine involuntarily leaves the bladder. My big clinical pearl here is that it is not a normal part of aging. So a lot of times we like to think, oh yeah, this is normal. It's normal to be incontinent. It is not normal to be incontinent. A lot of women don't come in and ask for help with it because they just think, yeah, all aging women pee their pants. That's not true. a weaker pelvic floor muscle is, have to use the bathroom more frequently is normal, but full on involuntary urine leaving the bladder, that's not normal and needs to be treated. It can really be a source of embarrassment. And it can believe him, like it can really take away a lot of their independence. They feel like they're not in control of their body. They have to wear a diaper. They don't like that. So it's something that we really need to address. There's three main types. There's urge, stress, and overflow. And you kind of need to be able to differentiate between these three types. Urge is going to be an overactive bladder. So that's going to be when all of a sudden they just feel like, I have to go so bad. I have to go right this second. Kind of similar to that feeling when you have a UTI, but it doesn't burn. Stress incontinence is going to be when there's too much pressure there. So like when they're laughing, if they pee their pants, or if they're jumping on a trampoline and they pee their pants. Really more common in women that have given birth before. And then lastly, there's overflow incontinence. That's when you get that incomplete emptying because of things like benign prostatic hyperplasia, BPH, that can cause overflow. But urge is the most common type. That is caused by the overactive detrusor muscle in the bladder and then just bladder hypersensitivity. So remember, the bladder gets smaller, it can't stretch as much, those detrusor muscles become overactive, and the bladder becomes really sensitive, especially to irritants like caffeine, sodas, things like that. So you're going to want to get a really good history, ask them about symptoms, because we don't want to miss something that could be a UTI and just say, yeah, that's urgent incontinence. Because you want to know, like, if they're having urgency, like, what's the frequency? Does it hurt? Is it blood tinged? Things we don't want to miss. There's a lot of medications we can use to treat. I like to go non-pharm first, and that's what I would always recommend in practice is you start with relaxation techniques, avoiding bladder irritants, doing training, pelvic floor training, especially for older adult women. Um, if that's not helping and it's really affecting their life, you're going to want to do things like oxybutynin, but it does have an anticholinergic effect, all of those drugs. And so they have a lot of bad side effects. And that's why I always like to start with non-pharmacologic options first. Chronic pain, it's really complex in older adults. My rule of thumb is number one, do not reach for an opioid. And then number two, still don't reach for an opioid. We really try to avoid high level drugs like that. The best options for older adults, especially for things like osteoarthritis, are going to be acetaminophen, NSAIDs. If you're going to do an NSAID, make sure you're doing it with a PPI. Neuropathic pain becomes really common, especially in diabetics, that tingling sensation in their feet that's really irritating and it hurts. We don't have very good drugs for neuropathic pain right now, which is unfortunate. Our best options are going to be those gabapentinoids, but they make you really tired. So that's going to be something you want to prescribe at bedtime to see if it helps with their pain. Second line, if it's really, really bad and they're really affecting their quality of life, is TCAs, because I hate avoiding TCAs. I mean, I hate prescribing TCAs, so I really try to avoid them. But if there's no other option and their quality of life is terrible, there may be an argument for starting them on it because it has been shown to help a little bit. Opioids, we only ever use short term for very severe acute pain, like they just got a hip replacement. And you want to use that at the lowest effective dose, shortest duration. And if you are going to prescribe it, do not forget the stool softeners, because I promise you, constipated patients are very unhappy. They do not forgive or forget. So do not forget the constipation prophylaxis. Sleep problems, like I said, insomnia is really common in older adults. But most of the causes are reversible, like being in pain is a big cause of insomnia, medication, stress, late night episodes of The Office. So we want to make sure that we're first teaching good sleep hygiene, like going to bed on a good schedule, avoiding caffeine before bed, not avoiding blue light on their phone or on their TV before bed. Daytime naps become really popular as people get older. We want to avoid those. And then diphenhydramine is going to be a hard no for me all the time. It does make people sleepy, so a lot of older adults have been taking it for years to go to bed. The anticholinergic effects are awful for older adults. And then on top of that, it is linked to dementia. So we always avoid those. Melatonin is going to be your best gentle friend. Trazodone's okay at a low dose, still not my favorite. I would say sleep hygiene, melatonin are going to be your best options. Nutrition, you want to do weights at every single person, because unintentional weight loss in older adults, it's like your biggest red flag. So you want to check for depression, cancer, dentition, like are their dentures not fitting right? That's a weird one, but a pretty common cause of unintentional weight loss in older adults. They're not eating very much because their teeth hurt. Loneliness can cause unintentional weight loss. So big red flag, you want to always check it, and you're looking for over 10 pounds in 6 months. That's what we consider to be, nutrition frailty issues. Frailty is that other thing that is like this big thing you don't want to miss in older adults. So remember, make sure you're educating on drinking ensures, making sure their weight is ideal. And then if it's at end stage disease and they're really just not eating, they have no appetite, a drug called magestrol or metazapine, those are really good to help stimulate appetite. So I've seen those used more at later in life, severe disease, like they just really can't gain weight. We're going to skip this case study today. Answer really is just that if they've had an unintentional weight loss, you want to get labs, do screening, check all that stuff. We're just kind of out of time. Um, Last couple things here, arcus sinalis, that's benign. It's that gray ring around the eyes in older adults. It's usually due to lipid deposits. If it's on both eyes, that's normal. If it's just on one eye, that's when it's a little concerning. Like I would do further workup if I saw it only in one eye, but that gray ring around the eye, normal in older adults when bilateral. It is kind of a sign of hyperlipidemia, so I will, if I see it, even if it's normal, I'll always grab a lipid panel just to see where they're at and if they need to get put on a statin. Then you have cataracts. That's that like their eyes just look cloudy. It's most common in the elderly. 50% of people over 80 have cataracts. So it is pretty common, but it can affect their vision. It can make their vision blurry. They can see halos, muddies up the colors in their vision. So this is usually going to be what you refer out to an eye surgeon to see if they want to remove them with eye surgery if it is affecting their vision. Macular degeneration, that's going to be that center's gone, but the edges remain. Like everything's kind of distorted and they have like a black hole in the center of their vision. That's really genetic. You can have wet versus dry. It's like one of the leading causes of blindness in older adults. So you want to make sure that this gets referred out to an optometrist, that they're managing that. There's a lot, I mean, nowadays we manage it with like little needles in the eyes. There's so many different treatments. But make sure that you know that it is diagnosed with an Amsler grid and that it causes the center of the vision to be gone. Those are super important. For glaucoma, same age risk factors, except for it's more common in African Americans, where macular degeneration is more common in smokers. With glaucoma, that's going to be that tunnel vision, where their peripheral vision loses and they start to focus in because of this excess pressure. So this is usually treated with like eye drops, beta blockers, sometimes surgery, depending on the type of glaucoma. But this pressure in the eye is going to be really high, so it's something we want to monitor and not miss. And then lastly, there are hearing changes. So presbycusis, that is that gradual hearing loss. It's high pitch. So I know a lot of times when we get louder, our pitch goes up. And so the most important thing when you're talking to older adults is dropping your pitch, speaking low and slow at eye level so they can read your lips. Um, Age is the biggest risk factor for this, but also you want to not forget frequent exposure to loud noises, genetic predisposition, smoking's a risk factor. Certain medications can cause it as well. So in the early stages, a lot of people won't even notice that their hearing's affected. It's going to be their spouse, their family member that notices first, that say, I have to repeat myself all the time. Or I had a patient who they didn't even notice their hearing was changed. Their spouse noticed that they always watch TV like this, with one ear facing the TV, because this was the ear they could hear better in. And we tested one of their ears. They had like very little hearing in it, and hearing aids fixed the problem right up. So we want to make sure that we screen that and we refer out to an audiologist. Okay. We'll go back to this slide one last time, and we're going to end just on a few questions, guys. I know this has been very long. I just want to know, how confident are you guys feeling about caring for geriatric clients? Did this improve our score? I want to see how everyone is feeling now. If we're getting some improvement here. Okay, this is good, guys. This is a higher level. So I am glad to hear that people are feeling a little bit better about geriatrics. That is good for me to know. And then last question before I let you guys go. We do a couple webinars a week, and I always want to know what you guys are looking for. Like, what are you struggling with, especially those people in the audience that are retest takers? What do you find to be hard that you want more practice on? I'm always looking for good ideas here for what we want to do. I'm doing another webinar on Thursday if you want to sign up for that for another CEU credit that is going to go over screening guidelines. So that's another option for you guys. If you can't think of anything right now, don't worry, you can always email me with your ideas if you think of something later on. For the person who commented about the registering for the 3-day live review course, we're not doing one in May right now, like I was saying earlier, just because we're in the middle of some really great content development for you guys. But if you go ahead and email us at nursepractitioners@archerreview.com, I will go ahead and get you, we can work something out to get you over a link to a previous 3-day live it's going to be recorded, so you can't ask questions in live time, but you can definitely still watch the videos. It's going to be the same content to help you prep, because we don't want you guys to miss, those of you that just graduated and are taking your boards, we don't want you to miss that content. So definitely reach out to me and let's see what we can figure out, whether it's a tutoring option with me or getting you that recorded 3-day live content. I want to make sure that we get that over to you guys. Pharmacology, farm tidbits, musculoskeletal. I really like this idea for farm tidbits. So I think I'll write down all these ideas. I like the idea of something that's like farm must-knows, like the highly testable medications, first-line treatments, etc. So I will work on something like that. Diabetes. Whoever said that, you have my heart. I love diabetes. I'm trying to get one of those webinars on the schedule because there's a lot to know just about diabetes and diabetes treatment. So we will end there, guys. Thank you so much for joining. I appreciate your guys' time. It has been wonderful having you guys here joining for today. If you have any questions, don't hesitate to reach out once again with our email. Where was that? Can't remember what slide that was on. It's nursepractitioners@archerreview.com. So there it is right there. Yeah, nursepractitioner@archerreview.com. Reach out to me with any questions, anything I can help with. Good luck to all you retest takers, you future test takers, those in school.